Bore da, a croeso. Welcome everyone to today's meeting of Powers Teaching Health Board. It's a beautiful day and looking out of my window I can see spring is coming, which is always good news. I'm Vivian Harpwood, Chair of Powers Teaching Health Board, and you'll see on screen details of the independent members, the executive members and any additional attendees who are present in today's meeting. There have been two apologies from two independent members, Ian Phillips and Francis Gerard. Katie Blackburn from the CHC and Dave Thomas from Audit Wales will be joining for their items in due course. Please be aware that participants may look away from the screen to consult their notes, particularly when presenting, to enable them to access documents. So moving to the agenda then quickly, which is published on the website along with the papers. Board members will be aware that we're currently operating our board committees in a very focused way, concentrating purely on key issues, and it will be assumed by the presenters that papers have been read in advance, as of course they always should be, to make the best use of time if there are any questions from the independent members. Can we turn then straight to the agenda? Are there any declarations of interest, please, about which we are not currently aware? No, good. So can we go to the minutes of the last meeting, which are with the papers? I'm assuming that you will have read these, but very quickly, ignoring any typographical errors, because Liz and I went through it yesterday and have already corrected them, although it's always possible to miss something, of course. Can we just turn to page 1, page 2? I'll be as quick as I can. There are 23 pages. Page 3, page 4, 5, 6, 7, 8, 9, 10, 11, 12. Do shout if you come to something you'd like to say is not a correct record. Page 13, 14, 15, 16, 17, 18, 19, 20, 21, 22 and 23, and nobody has spoken. So, Trish Buchan. Thank you, Trish. Page 22, you've spotted a point of accuracy.
Yes, I was hoping I'd actually requested that I raised the neonatal transport work with Carol. We did try to arrange something before Christmas, but obviously COVID intervened. But I would still like that to happen, please.
Okay, thank you. I'm sure that'll be all right with Carol. Do you want to come in on that, Carol, and we'll make an arrangement for you to meet perhaps after the meeting?
Yes, thanks very much. And you're absolutely right, Trish. I thought we had something go into the diary, but it seems to have come back out again. So very keen to catch up with you on that. We discussed neonatal transport and the update on that at a recent WISC meeting as well. So there'll be a further update from me on that.
Thank you.
Thank you, Trish. Can we then please record that these are an accurate record of the proceedings of the last meeting? I'd assume, as there are no no's, that's a yes. Thank you. And are there any matters that are arising from this that are not in the action log or otherwise on the agenda? No, I can't think of any. So could we then please turn to the action log? And there are only 3 items there. I think we can dispose of the action log quite quickly. Any comment either from the Chief Executive, Director of Planning and Performance, or the Board Secretary? No? I can see that these are being dealt with. Thank you.
Actually, sorry,
yes. Okay.
if I it's Trish back in again.
Yeah,
just to say that we did actually have a discussion about the neonatal transport in South Wales at the last independent members meeting.
Yes.
So it's an action that's completed.
Yes.
In that sense.
In that sense, right? I see what you mean. And I mean, it is a very long-standing issue. It's been around for, well, I wouldn't like to say how long, and it is an important issue. All right, thank you. Thank you, Trish. Right, so if everyone's content, we'll move on to the reports from the Chair and the Chief Executive. We do not currently have a Vice Chair, but that is the first point you will see in my report. I'm going to take this as read. I don't propose to speak specifically to any of the items, only to say that it is imminent that the name and appointment of our new Vice Chair will be made public. So we look forward to that very much. And in terms of the other items, they're happy to answer any questions. Okay, I'll go on then to ask Carol to come in with her report.
Thanks very much, Chair. I'll take in your lead. I wasn't planning to go through the report very much, but what I did want to take an opportunity to say is that we will obviously cover system resilience in a little bit more detail on the agenda itself. It's been a tremendously challenging period for the country and the NHS since the last board meeting. I wanted to flag that we would normally do the integrated medium-term plan in our January meetings. That has now been put back to March. A Welsh Government have extended the submission date to the end of March. And I just wanted to pause a moment on senior staff changes and to recognise that this will be the last board meeting for Alison Davis, Director of Nursing and Midwifery, before she retires. We will get a chance, I know, to thank Alison for her leadership and contribution to our board and our organisation before she does leave us, and also to Stuart Bourne, Director of Public Health, for his contribution as well in leading at what has been probably the most challenging time for any public health director leading through the pandemic. So I know that you'll want to say something else on that, Chair, when we get an opportunity, but I wanted to draw that out of my report and thank them both personally from my point of view for their contribution.
Thank you, Carol. And for my own part, I'm very sorry to be saying goodbye to two excellent members of the team, but perhaps we can embarrass them a bit more at the end. I can see, Carol, that you have told me in the chat bar that the announcement was made by the Minister yesterday. So it is public knowledge that Kirsty Williams will be joining us as our new Vice Chair. And if she's listening, welcome, Kirsty. But I understand that there are one or two formalities which still need to be carried out before we can be absolutely certain that Kirsty is joining us. I know it's inevitable, so I'm delighted. Thank you for that, Carol. I hadn't realised. I'd been watching and not seen that. So
I caught it late last night, ministerial statement, which of course is a government appointment. So thank you. Of
course. Yes. Thank you. Right, so we can proceed with the second section of the agenda, where there are items for approval or ratification or decision. And we'll go straight, please, to Stuart, who will introduce this first item, the Civil Contingencies and Business Continuity Plans.
Yes, thank you, Chair. If I may, I'm conscious there are two plans here today, and they're here because they're very much interrelated. So they're here as one. If Board are content, I'll briefly summarise both the major incident plan, but also the corporate business continuity plan, and then I'll be happy to take questions on either plan afterwards. But I'll run through them both relatively quickly. Thank you.
Yes, please. Yes. Thank you.
As indicated, I'm seeking approval today for the Corporate Business Continuity Plan and the Major Incident and Emergency Response Plan. I should just note that the Major Incident and Emergency Response Plan was previously called Civil Contingencies Plan, and I'll briefly explain why we've changed the title of it this year, but just to note that it was previously described in that way. We're required as a Category 1 responder under the Civil Contingencies Act of 2004 to have these two plans in place. Both are ordinarily reviewed on an annual basis, and we have in previous years reviewed it in the December period each year and sought to get it refreshed and re-ratified. I should declare that we did not do that in 2020 due to the pandemic situation, but it is coming to board now, although slightly delayed. We would have otherwise tried to bring it around Christmas time of 2021. So it's coming at the beginning of 2022, and we will aim to bring another annual update at the end of the calendar year, so again in December. So just to explain a little bit about the dates on the front of both plans, just to clarify that. And I should just note that the Major Incident and Emergency Response Plan has always come to board for approval, so it's come on an annual basis for approval from board members. The Corporate Business Continuity Plan hasn't come previously. It's been approved through Executive Committee, but because of the interrelationship between the two plans, but also because of obviously, understandably, a heightened focus on emergency planning currently, we felt it was justified to bring both plans really as a package to board and to seek board level approval for both of the plans going forwards. Both plans have really had a general refresh and update. It reflects some of the learning from the pandemic, but we have to recognise that there is also a separate pandemic framework, a mass vaccination plan, and there's also a communicable disease outbreak plan for Wales. So it has some of the learning from the pandemic in the update, but these two plans are not primarily describing our response to a pandemic. There are separate policies and plans which will inevitably be subject to refresh and update in 2022 as we reflect on our learning from the pandemic. So if I just start briefly with the Major Incident and Emergency Response Plan. So really the aim of this plan is to ensure that as a health board, we're really able to respond, particularly in partnership, to a major incident or an emergency. And in the partnership context, it really has a relatively set format and content, and that's to ensure that we're consistent in our approach and how we describe and frame a major incident with other Category 1 responders, particularly police, fire and rescue service and Welsh Ambulance Service. So there is a level of consistency across major incident plans across all Category 1 responders to reflect that partnership approach. And essentially it describes the framework for responding to what we might describe really as a classic big bang event, particularly things like large transport accidents or even a chemical, biological or radiological event. It's a plan that we use really when we've got those big incidents that might hit. And it sets out the command and control, the reporting arrangements, and how really we would work in partnership with colleagues in responding to that type of large-scale event. Just in terms of the changes for this year, alongside just a general refresh, the plan has been renamed, really to recognise that it provides a framework now for responding to a wide range of incidents beyond those that were classically involving perhaps mass casualties. So there's reference now to perhaps cyber incident events or where we might need to carry out a hospital evacuation. So that renaming of the plan is really to give due recognition now to the fact that we're talking about a wider range of events that might be declared a mass incident and might not necessarily mean we've got large casualties to deal with. The classification of incidents has been amended, so we now have a new definition of a critical incident, and that's defined on page 16 of the plan. There is a greater reference and alignment to the corporate business continuity plan, and you can see that in the plan itself where we do reference the business continuity plan. And then the other minor change is we've moved the location of the Health Emergency Coordinating Centre on our site. It was previously where we've just developed the Health and Social Care Academy, so we felt it was appropriate probably to move it from there. So it's now been relocated to Glaisbury House. And then just to finish on the major incident plan, it's also just a note really that we are expecting some work on an all Wales basis to happen this year around mass casualty arrangements, and that might lead to a further iteration of the plan in due course over the next 12 months. But we will aim to bring another update at the end of the year that will cover and include those changes. If I just move on briefly then to the corporate business continuity plan. Essentially, the aim of this plan is to set out the organisation-wide coordination and management arrangements, specifically in relation to level 3, which is defined as an enhanced coordination situation, or level 4, which is more of a major business continuity incident. Essentially, this plan provides the gold on call, particularly with a framework to both assess the escalation level of a business continuity incident, but also sets out how to respond, including things like establishing strategic and tactical coordination groups and some of the decision-making tools that would need to be used in terms of responding to a level 3 or level 4 incident. And that's described really in section 4 of the corporate business continuity policy. It's set out there. It doesn't prescribe a set of specific actions, as that very much depends on the type of disruption, and a different type of incident will necessitate a different course of action. So it isn't prescriptive in that way, and neither does it contain the actual service level business continuity plan. So individual directorates and services in the Health Board will have their own business continuity plans that they keep up to date. This is very much to support that senior executive or gold on call to respond if we have a larger scale business continuity incident. And then similarly, alongside a general refresh, we have aligned this plan more closely now with the major incident and emergency response plan, recognising really that both plans can come into play at the same time in dealing with an incident. Just as an example on that, the escalation levels on page 12 to 14 are now clearer about when a business continuity incident is likely to become a major incident, and then the command and control response would need to kick in. So we have tried to align the two more closely this year. And then just some other relatively minor changes. Previous version of the plan referenced EU withdrawal. Given where we are now, we have removed specific reference to EU withdrawal, but we are referencing some of the other wider challenges now, e.g. the response to the pandemic. So there's been a slight refresh to reflect just the moved position in relation to EU withdrawal. And then there have been some changes to how we categorise the priority services that would need to be maintained, really following some Welsh Government guidance last year about how you define and describe what is an essential service. And we really took that from our pandemic learning that came out of the response to the pandemic this year. So, Chair, that's a brief summary of both plans. They're both really a general update, conscious that the business continuity plan is coming to board for the first time, that the major incident plan in a different heading has been previously tabled for approval on an annual basis, and subject to approval from board today, we will then begin a process of disseminating and communicating those changes to staff. I think probably just before I finish, I would note that I would personally like to see, if we do get the opportunity this year, a chance to exercise some of these plans this year, because I think that helps just to embed some of the principles within how we respond as a health board. But I am conscious that really last year and also the year before, we've not had that opportunity due to the pandemic. But I am hopeful this year we will be able to help to embed these plans through a process of exercising. Thank you. Thank you, Chair.
Right. Thank you, Stuart. I'm sure there will be some questions for you, and I can see Ronnie Alexander is the first person to have a question.
Thank you and good morning. Stuart, I thought these plans were very clearly set out, and I'm grateful for that. It's interesting, of course, to reflect that the Civil Contingencies Act is now 18 years old, and that was a surprise to me when I thought about it. But just coming on to the specifics, these plans, of course, are part of wider LRF arrangements generally. And given that the boundaries between the Health Board and the local authority are completely contiguous, I'm assuming that there is also a process of review of these plans that's underway in the local authority. I ask that because given a Big Bang incident, as you describe it, or CBRNE, there might be a need to identify vulnerable people. And so the need for close liaison between the local authority and the Health Board would be paramount in such a situation. And my second point is I'm pleased that you referenced the need for testing, and I would suggest that this may be a high priority for the coming period. Thank you.
Yes, thanks, Ronnie. A couple of very good points there. I think if I take the latter one first, yeah, I absolutely share your view, and I was keen to recognise that producing plans is helpful, but actually unless you test and exercise those plans, they really don't get, or there is a risk that they don't get embedded and operationalised fully. Partly linking back to your previous question and putting the two together, pre-pandemic, so probably 2 years ago now, back to 2018 and before, LRF partners, there was quite a healthy process actually of testing on a multi-agency basis in response to certain events, and I can recall going to certainly one or two organised through Dyfed-Powys Police in relation to big Bang critical incidents, and I think both on an LRF basis and as I've alluded to, certainly on a Health Board footing, I would like to see both of those really start this year, because I do think we need to try and introduce that. I will also note that LRF partners have now reconvened the Gold training, so the 2-day training for particularly Gold on Call, which is obviously critical for some of the operation of these plans. They've restarted now the 2-day training for people that are Gold on Call in how to respond to major incidents, and I think that's welcome as well. That was curtailed during the pandemic. In particular about the local authority, you're absolutely right, Category 1 responder, they have the same requirements and responsibilities to have these plans in place and to keep those plans in place, and we work pretty closely with the emergency planning team in the local authority. We worked very closely during the pandemic, but more generally we have had quite close relationships with local authority colleagues around some aspects of planning. Particularly I'm thinking about things like excess deaths. So I would hope that as we go forward into this year, we'll get that opportunity on a multi-agency basis to review and retest some of those plans in a more partnership arena than we perhaps have done to date.
Right, thank you. Carol, you wanted to come in now, is that all right?
Yeah, lovely, thanks very much. I just wanted to make a comment that clearly these sorts of policies and arrangements under this legal framework have been tested during the pandemic. We did take an opportunity after the first wave back in 2020 now to take some reflection and some learning in the organisation. I'm very keen that we look to take that opportunity again, possibly in the next couple of months. But I also really wanted to point out that the pandemic inquiry, the chair has now been appointed into that. The pandemic inquiry may also have learning that we transfer across into this. So we've certainly tested out business continuity planning in action, but I'm pretty sure that there will be some broader reflections for us organisationally and nationally that will be useful learning to take into this type of emergency planning for the future. And I just endorse Stuart's comments about the GOLD training. I did my refresher training probably 3 years ago now, certainly just before the pandemic. Extremely useful and very helpful to have the Dyfed Powys footprint and all the different agencies as part of that.
Thank you, Carol. Some very good points there. Actually, we look forward to the inquiry because we will have things to learn from it. Trish Buchan, you want to ask a question?
Yes, please. Thank you for the presentation. It does give food for thought. It's really well laid out and understanding. My question is really about other NHS partners in Wales. As an organisation, we have a high level of interdependency with our neighbouring NHS organisations in Wales, Welsh Ambulance Service, but also our cross-border partners. Do we take cognizance of their plans, or how do we make sure that we interdigitate with them?
I think the cross-border question is a good one, Trish, and if there is probably a gap in the partnership arrangement in Wales, I think it is that English-Welsh border arrangement. I'm probably more confident about the partnership arrangement within Wales insofar as my practical experience really of through LRF partnership arrangements, notwithstanding the all Wales nature of agencies like WAST, they are and have been diligent and consistent partners around the LRF table. So I can recall previously when we have had exercises on a Dyfed Powys basis through the LRF, WAST have been around the table together with Welsh Government as well. So the regional partnership working, I think, within the NHS and about the understanding of who does what in response to a major incident and how we would coordinate, particularly in response to a major incident, I think historically has been quite well tested and has had good partnership engagement. I think if there is a gap, it's probably the other point you make, Trish, which is a good point about the English-Welsh relationship and how we work across that boundary between England and Wales in terms of the health, but also perhaps the partnership response.
Thank you, Stuart. I can see there are no more questions. Could I ask the board then, please, to approve the Major Incident and Emergency Response Plan and the Corporate Business Continuity Plan? Thank you. So those two plans have been approved. Could we move then to the next agenda item, and I'll call on our interim board secretary, James Quance, whom we're delighted to see, to talk to the next paper, or to introduce anyway the paper.
Thank you, Chair. Good morning, everybody. This is the latest in a number of papers to board during the pandemic, explaining how we are maintaining good governance, proportionate to the rapidly changing nature of the pandemic. And it describes how we're operating with more focused agendas and committee time, as you mentioned at the start, during January and February, during that period. And this is, of course, being kept under review, given the rapidly changing nature of what we're dealing with at the moment. It's the culmination of a process of briefing of members, and a chair's action was approved on the 14th of January, prior to the commencement of this committee cycle. I wasn't planning on going into a great deal more detail, given the briefings previously provided to members and the papers are go into quite some detail themselves, but I'm happy to take any questions with regard to those papers, and the request is that the board ratifies the chair's action of 14th of January.
Thank you, James. Yes, very clear explanations in the papers. Thank you. Are there any questions? No. So could I then ask the board to ratify the decision taken on the 14th of January in chair's action in respect of maintaining good governance? Thank you. And we move then to agenda item 2.3. And Hayley, would you like to introduce this?
Diolch Cadeirydd. Mae'n bleser gen i roi'r gwybodaeth diweddaraf am rhaglen ar lles Gogledd Powys, a dwi'n cyflwyno hefyd memorandwm cyd-dealltwriaeth ar gyfer datblygu y campws arloesol yn Drenewydd i'r Bwrdd Gymeradwyo hefyd. Thank you, Chair. I'm really pleased today to bring this update to the board on the progress that's being made around the North Powys Wellbeing Programme. Today's paper sets out a general update on where we are against the programme in delivering the key pieces of work and the timetable against the timetable, but also an important document, which is a draft memorandum of understanding for the multi-agency wellbeing campus, which we have worked together with the local authority to draft in partnership, and setting out some of the key principles and arrangements for how we will work together in creating the new multi-agency wellbeing campus development in Newtown. I think it would be fair to say that during this time, the team currently are working very hard. This programme is our flagship programme for the Regional Partnership Board. And the board members will be aware that we submitted a programme business case to Welsh Government over a year ago for this really important piece of innovation and development for the region of North Powys. Just to give you an update, we are working on the strategic outline case currently, and that is in its final stages of development as it goes through the relevant approval processes, both internally but then onward to committee and to board within the Health Board, and to onward to the Cabinet within the local authority, and also importantly back to the Regional Partnership Board. In relation to the strategic outline case, just to give you some key updates really, apologies, I've got a tickly throat this morning. We have got re-engagement activities that have restarted, and we're very much in working in partnership across both health, social care, education and housing, particularly working with the local communities around how we will take forward the detail in the strategic case. Informing that is some really important work that we've done on the demand and capacity modelling to inform the future model of care. And in the paper, it sets out some of the key messages that have come out from that demand and capacity work. One to highlight is there's lots of opportunities around how we can do things differently in North Powys to deliver the vision as we've set out in our long-term health and care strategy, A Healthy Caring Powys. The strategic case, as I said, will be coming through to Cabinet and Board in March. And today, I just wanted to say that the Memorandum of Understanding that has been drafted here, this paper and the Memorandum of Understanding has been considered in the Planning, Partnerships and Public Health Committee. And it was really helpful. It has also been discussed within the local authority. So the current draft of the Memorandum of Understanding that's shared for approval today has got just a couple of key additions added as a result of the local authority meeting after the public meeting of the Partnerships, Public Health and Planning Committee that we held. So if I draw your attention to those members. So firstly, on page 1, under the Memorandum of Understanding, under Principles, there was a particular lead from the local authority to ensure that there was reference to the school governing body in the principles around engaging with all key stakeholders. So that was a minor amendment. And then on page 3 of the Memorandum of Understanding, which you have a copy of, there was some just additional wording requested under the section of costs, which were the wording of these arrangements will need to be specific about the costs defined in any agreement, the contributions to be made by each organisation, together with the charging mechanism and payment terms. So again, just more descriptive, doesn't fundamentally change the content, just more descriptive content requested. And the final point that was added in, and we did discuss this in the committee meeting, was on page 4 of the Memorandum of Understanding, an addition of a section called dispute resolution. Now, what we, and that's about arbitration between the chief executives of both organisations in the case of any disputes. What I would say is that this is a work in progress, and this reflects the stage we're at in this programme, which is at a strategic outline case. And as we move further forward with refining the detail and securing the funding for this important work, the Memorandum of Understanding will need to mature, contain more detail, and actually have much more stronger legal basis as we further develop the programme case through the business case process. So it's a work in progress, but we felt it was very important to bring it first to this meeting prior to the SOC coming to the board in March, because particularly for the local authority and the health board, this is a much more formal arrangement now with more detail setting out the way in which we work together, which I think is very helpful for us to secure together in partnership, particularly recognising that we have a very small window to approve the strategic outline case in March, as both organisations, before the pre-election period starts for the local authority elections. So that was all I wanted to say, Chair, and I'm happy to take any questions that members may want to raise.
Thank you. Thank you. Clearly, this is crucially important for the people of Powys, particularly in the north. I can see Robert has a question. Robert Lewis, independent member.
Thank you. And this is a very exciting beacon project, and I'm sure other health boards and trusts will be monitoring the progress on this as well. As far as my interest, really, I'd like to mention the modelling on the diagnostic imaging services, and I'd like to just probe what early modelling indicates means, because obviously the cost of a CT scanner is going to be, very, very high. So does it mean that some work has been done on whether there is it's viable to have such a scanner, or does it mean that there would be the demand? That's question 1. And just question 2, could you confirm that considerations of imaging are going to be considered alongside an all health board analysis of diagnostic services moving forward? Thank you.
Yeah, thank you. Really important question there. So this work is obviously in the context of the North Powys Wellbeing Programme at the moment, but just wanted to reassure you that under the renewal portfolio, the team are working on a pan-Powys diagnostic strategy, which hopefully will be available in the next couple of months to again go through the approval processes. So we're working very hard on the diagnostic strategy for the whole of Pan Powys, and I think that's an important point, because in terms of this particular development, we will need to make sure that it's the the first campus, multi-agency campus that we'll be putting forward to Welsh Government, but it is important for the model of care that we're developing that is recognised as Pan Powys, and we will have a detailed diagnostic strategy for the whole of Powys. But unfortunately, we've just probably a little bit in the wrong order. We should have done that first and then do the detail of this. So we're working concurrently on both at the moment. So just to reassure you, there will be a Pan Powys diagnostic strategy. The second point is that the modelling that's been done has been based on the available activity that currently and demand on for these services at the moment. So we haven't yet done the detailed financial analysis of the various component parts. But what we have done is we've done benchmarking. We've also looked at the Richards report. We've looked at the requirements, and what we're seeing from this early modelling is that there's sufficient activity to justify. We will still need to do further work to make sure that that actually is a financially viable approach to take forward. But again, the big issue here is the benchmarking work that's been done. Once you hit a certain threshold of numbers, you then have a viable service. And we'll be in discussions. Some of the areas that we'll be looking at also is recognising the strategic location of Newtown, is whether we'll be able to work in partnership with other health boards in terms of supporting them more widely around this, which will again increase the viability of the business case. So I would say, yes, we've done it on the numbers, the expected demand of the next 10-year period. What we haven't yet done is the detailed financial analysis, which will be undertaken at OBC stage. And the final point is that this is quite long term in terms of the programme business case around capital. If we have we can test some of these ideas as we go forward. I'm personally very keen where we think we've got areas which are new that we need to test out, that we might be able to, whilst we're taking forward the programme business case for capital investment, be testing this out through potentially more mobile options that could come into the county. So I hope, Robert, that answers your questions, but I'm happy to take any further queries if you'd like.
No, very thorough answer. Thank you very much, Chair.
Thanks.
Thank you, Hayley. Could I ask Trish then to come in with her comment?
Okay, thank you. Thank you, Hayley, for the presentation. As Chair of Partnerships, we gave this a really thorough airing at the meeting. I think our view was very much that we welcome the North Powys project. It is ambitious, it's cutting new ground, if you like, but it is important that we strengthen governance around it. So we really welcome the Memorandum of Understanding. It's just to say that we did receive one of the issues that was raised at that meeting was about, if you like, the timing of decisions being made by the council and by the health board and tweaks and changes. But we did receive an assurance from Hayley that there'll be close conversations going on between the different officers involved throughout the time. Do you want to come back on that?
I'm happy to. As I said, the formal meetings, Trish, that we've got is the Cabinet on the 1st of March and then our board meeting on the 30th of March. And, you know, we have got a compressed window there. We've got really one bite at the cherry prior to the pre-election period for this, which is why we've got to work so closely over the next few weeks to make sure that every issue that we think might come through is addressed. We've also got sessions with the local authority, with the scrutiny committee coming up as well prior to that coming through on the 1st of March. So it is tight in terms of the timescale that we're working to, but I feel confident. We might have some minor changes between the two meetings, which we'll have to discuss based on final feedback. But I'm really pleased that throughout this programme, the amount of support that we've had from the local authority, other partners and ourselves in wanting to get this over the line, I think everybody recognises that actually the submission of the strategic outline case in March is really important. So we're going to pull out all the stops to make sure that we deal with any issues that might be a problem for decision making in those final 2 meetings prior. We've also got a joint partnership board meeting coming up as well during that period, and obviously the regional partnership board as well. So, you know, I think that I'm reasonably confident that we will get to a position we can submit the strategic outline case, obviously subject to board approval and cabinet approval, and there may be some final tweaks, but I think, you know, we will have got, we will be in the margins of dealing with issues rather than fundamental questions about, you know, approval, if that's okay. I don't know whether Carol would want to come in to reassure as well, because I'm the senior responsible officer, but obviously as programme owner, perhaps Carol might want to comment on that point. But I'm giving you my assurances, but perhaps Carol may want to comment as well.
Yeah, thanks very much, Hayley. I recognise, Chair, there's no hand thing, so I was giving you a wave. Thank you, Hayley, for that. Just to pull both points actually. So Robert's point about diagnostics, I think if colleagues do get an opportunity to look at the review that was undertaken, it was an independent review by Professor Sir Mike Richards. There's some very interesting, it's a very interesting report about the future of diagnostics, the need to detect earlier disease, including cancer, of course, will affect positive outcomes. So we want to try and future-proof this for the people of Powys. So lots of really exciting potential in the diagnostics space. In terms of the strategic outline case, I think we will need to just make sure that we're really clear what a strategic outline case needs to do. It does not need to solve every single issue at this stage. What happens is you have a programme business case, which we have submitted to government, and we're anticipating we'll hear soon about that. The SOC is the next level, and then we go into more detail in outline business case, etc. So we will make sure, I think we've got a board development session in February, part of which is dedicated to this, so that all board members can really get quite immersed in the developments as we go. But from my point of view, I'd endorse Hayley's comments about how well as a partnership we're working on this programme. It's got huge potential, and starting to cement that in a memorandum of understanding, I think, is an important step. We will get into more detail as this programme develops. So I want to just note the huge amount of work that actually the North Powys team have been doing to try to make sure the wheels keep on the bus of this this development. So thanks, Chair. Just a couple of comments from me on that.
Yes, thank you, Carol. Actually, you've preempted one of the things I was going to say, which is that both parties to this memorandum of understanding are extremely keen to collaborate and really make good progress on this really exciting project. So if there are no more questions, can I ask the board, please, to approve the memorandum of understanding? Well, I can't see any dissenting voices or hear any dissenting voices. So yes, thank you very much.
Thank you.
Good. That brings us then to the next section on the agenda, and straight to our Chief Executive to tell us about system resilience. It's quite a long, potentially long item, Carol. So if you could give us perhaps 20 minutes presentation, then 10 minutes for questions and comments, that would be great. Thank you.
Yes, thanks very much. And I'm going to draw on a couple of colleagues in the relevant places, mainly Stuart and Hayley. So as you set out at the start of the meeting, Chair, we are operating in a continuing pandemic environment, and hence we are having very focused discussions and meetings in order to enable the organisation and working with partners there's sufficient space to really focus on system resilience. So my first slide really just covers a summary of where we are. That will move across momentarily. There we are. So just as a reminder, both in September and November board meetings, we outlined the approach and the progress on planning for system resilience, mainly because the Delta COVID variant through the summer was leading to increasing cases, significantly high cases, and the efforts in terms of trying to manage both the pandemic, making efforts on the backlog of care that Powys population has actually been a delay to supporting them, and a general non-COVID increase in demand. So we saw that through the summer and the autumn, and we were very much expecting, therefore, that winter would be an extremely difficult period. So we stepped up our preparation during November and re-established a delivery coordination group mechanism. That was a mechanism we had in place early in the pandemic and is multi-agency. So we'll touch on a little bit of the progress made around that. And then, of course, during the latter part of November and into December, the emergence of the fast-moving Omicron variant and the ask that was put to us of accelerating the booster vaccination programme. Significant system pressure in December and January, and a refocusing of priorities, some reduction in non-urgent, non-clinical work, and then a summary of overall, I think we can report good system resilience has been maintained in Powys. Now we'll give a little bit more detail on that, but I wanted to take the opportunity to recognise the huge efforts of leaders and managers and frontline staff at all parts of the organisation, and our colleagues in primary care and social care and the third sector, because it is through those efforts that we have been able to maintain thus far a good level of system resilience. The next slide, I just wanted to take you back to the annual plan. And of course, we knew that the winter period may be very challenging, and our focus on the COVID response and the essential healthcare would need to dominate in the periods of pressure. That is how we have approached this. So some of our renewal work has been reprioritised during this period to ensure that we can effectively focus on resilience through the few months of December, January, and we can pick up where we are in terms of heading into February. I'm going to just go next to the prevention and response and invite Stuart just to make a comment on that slide, if I may. So I'll just hand over to Stuart.
Yes, thank you, Carol. So the first thing I should note in this section is, of course, to recognise that the work we do around prevention and response is a partnership piece. So we have done and continue to work extremely closely with local authority partners, and I must express thanks to local authority colleagues who've been involved in particularly the Omicron wave over the autumn, winter, and over the Christmas period particularly. It's been really a combined effort to try and manage cases in Powys over that period. Just briefly, the chart gives, I think, quite a nice illustration of what the Omicron wave has looked like across Wales. Each line is a different health board, so you get to see there between really October through to mid-January now what that Omicron wave has looked like as it's run through Wales and each individual health board, and it gives you some sense of how quickly really things did escalate from mid-December onwards. Just to give a little sense of the numbers, so in that last week of December into early January, we had just over 2,400 new cases of COVID-19 that week. we had on one single day 458 new cases come through of positive cases for COVID. So really an unprecedented level of cases coming through that we hadn't experienced previously, both in Powys, but I think in Wales and obviously UK wide. What we did in response to that was we stood up our incident management team arrangements. So we have had and we continue to have incident management team meeting 3 times a week. So we meet on a Monday, Wednesday and a Friday, really to survey the situation and also to respond to specific outbreaks and incidents, be those in care homes, be those in workplaces, be those in our own healthcare settings. We have quite a well tried and trusted partnership approach now to identifying where those outbreaks are and then responding in terms of control measures on a partnership basis. And then just above that, our prevention and response strategic oversight group, which is the more tactical strategic response, moved from a fortnightly to a weekly rhythm of meeting in response to the escalation in cases, and Dyfed Powys Local Resilience Forum. So the wider regional partnership arrangement was both re-established, but also was re-established on a weekly basis, and that still continues. So we meet with wider partners on a weekly basis as well to coordinate the response. So really a very, very busy time over Christmas into the new year, and the reactive response in terms of that scaled up accordingly to try and respond to what was an extremely demanding picture over Christmas and into the new year. Thanks, Carol.
Yeah, thanks very much, Stuart. We'll just move on. We'll do the whole presentation and then come back for any questions. But in terms of the next area of really very significant activity since the board last met, of course, is vaccination, and such a key tool this has been in our armoury. And if I can just draw Hayley in on this, that'd be great.
Yeah, thank you, Carol. I think it's been a remarkable few months for the mass vaccination programme in terms of from the 14th of September, when we had the initial guidance around boosters for the over 50s, and how that's moved forward then to the latest position that took place in December, when we had the new target to ensure that we offer boosters to all eligible adults by the end of December. And together with that, we had additional guidance as well at the time for boosters for 16 to 17-year-olds, boosters for 12 to 15-year-olds who are in a clinical risk group or a household contact of someone who's immunocompromised, and also the planning work that we've been asked to do and are just starting now to deliver this month on the first and second doses for 5 to 11-year-olds in a clinical risk group or household contacts. I'm incredibly proud of how the whole organisation wrapped around this additional requirement in December to offer all adults the booster by the end of December. That took a whole organisation response from both the clinical staff, the leadership staff, but also support services, the third sector, the volunteers, and all of our partners to deliver that. And as you can see from this, we are now in a really strong performance position around the delivery of the booster programme. Following the announcements in mid-December, the ramp up was achieved in partnership. You can see from the 100 squares there, about 1 square represents 1% of the adult population in Powys, and basically we are in a position where we've got 83,000 adult residents of Powys who've received their booster, around 97,000 have received their second dose, and around 99,000 have received their first dose. So it is very, very busy period for the team, and in addition to that, we've also been ensuring that we've been delivering the vaccine doses to a large number of non-residents as well. For example, the frontline health and care workers who live outside the county. So in total, we've now administered just over 300,000 vaccine doses across as part of our POWIS contribution to this programme. And again, in terms of our performance, we've got the strongest performance of all health boards across Wales, and it's among some of the leading rates in the UK as well. So just extremely proud of the work that's been undertaken from the start on this programme. Do you want to move the slide on? Yeah. Did you want me to cover this as well, Carol? Yeah, happy to. Yeah. Oh, you're on mute, Carol. Sorry. Yeah. Okay. So just in terms of looking ahead, I just want to say we are now sort of maintaining our always open offer for people. We want to make sure that we leave no one behind, and we're now sort of back into the space of making sure that people who were unable to attend because they had a positive test result, or indeed could not attend or didn't want to attend, we are now re-inviting all those people and making sure that we're targeting those conversations to the areas across POWIS with the lowest uptake. And just to give you a bit of a sort of insight into that, one of the geographical areas with the lowest uptake currently on the boosters is Newtown, despite the fact that we have the mass vaccination centre within Newtown. So there's a lot of more targeted work that we need to undertake to make sure that we encourage as many people to come forward as possible. The big work now currently for us is the work on the 5 to 11-year-old at-risk children, and that is due to start, and we've got the delivery model agreed for that, and then continuing to offer the boosters for the 12 to 15-year-olds, etc., and the 16 to 17-year-olds takes us over the next couple of months quite substantial activity. I think the key issue for us here is there are still some unknowns in terms of some of the JCVI guidance that and decisions that might come through over the next few months, but we're running this programme as part of a national programme. And we've got really strong national programme arrangements in place. And the key focus will be now is how do we develop a business as usual approach to mass vaccination, recognising that we need to probably have an ongoing offer as we move forward later in the year and into future years. And that will be our focus. And depending on timing, we'll be wanting to come back to the board with a full update on the proposed delivery model for how we would take that forward as soon as possible. But again, working in concert with our national partners and stakeholders on that particular piece of work. So I wasn't going to cover any more, Carol, unless you wanted to pick up anything in particular.
Great, thanks very much, Hayley. Just a footnote to what you've said, and this is a Wales number. It looks as though in each of the last 2 weeks, 5,000 people each week have come forward for their first dose, about 15,000 per week for their second dose. So it is really an important message that if people have put off having a first or a second dose, it is still a good idea to come forward. And the service is there to support that. I thought I'd just take the last 2 slides, Chair, and then open up to questions. So on service matters in particular, we have been able to maintain service provision across all service areas, despite really quite significant staffing challenges. The combination of vacancies and sickness amongst our colleagues took us to actually an absence on sickness over 6%. We have fared better than some, but that was really quite high for us, and we can see that that's falling a little now. We have had some colleague movement, staff movement through flexibility. We haven't had to suggest invoking the local options framework, which would mean the potential reduction or suspension of clinical work, but we have reprioritised some non-urgent, non-clinical work and reduced some of that for this period. sterling work in terms of ensuring that we were able to maintain flow of patients through the hospital system. And we may well pick a bit more of that up under the integrated performance report a little bit later on. But we have been able to bring patients who are in district general hospitals back into Powys with the minimum of delays. Planned care services, I know that there was a particular focus last week on waiting times as the national report was published. We have been able to make progress. Again, we'll pick that up a little bit later, despite some challenges to staffing. And then just finally, I wanted to mention mental health services, a particular pressure in mental health services over the last month or two. And again, a very sterling job by leaders, managers and frontline staff to maintain those services. And there's been no issues of supply chains to report. So that's really where we were able to indicate that we had a good level of resilience across the system. And then just finally, the current position now, staffing absences are falling below 6%, but still higher than the level that we're used to. We have maintained some staff redirection for this period, and that's likely to continue for a little bit longer. Our insourcing for our waiting list patients is still on track, and we continue to plan for go live early in February. I'm sure people who are waiting for a procedure will be very pleased to know that that has not been affected by this recent wave so far. And you saw earlier the report on the command structures and the resilience with the Dyfed-Powys LRF. So moving forward, if we do feel that we're coming through this wave of the pandemic and an equilibrium is sort of being reached on that, we will want to be lifting our head, thinking, moving from resilience to recovery and into renewal, again, given our ambitious agenda. I'll leave it there, Chair. Obviously, happy to take any comments or questions.
Thank you. Yes, and thank you so much for that presentation. It really does give a flavour of the hard work, I mean, the huge volume of work that's been carried out by our staff and partners and working so collaboratively, throughout the whole pandemic to ensure a good level of resilience. I'm particularly proud as chair of our performance on vaccinations. I mean, I feel as though every All Wales meeting I attend, I'm basking in what should be the glory accorded to the staff who've done all the hard work. But I'm always so proud to be able to point to, the performance of Powys on vaccination. So thank you very much. Some questions now. I've rather hogged that, haven't I? Ronnie.
Thank you. The figures on COVID vaccination are indeed impressive. I wondered if the vaccination programme for staff on flu is still continuing, and has the response been reasonable thus far? And if the programme is still continuing, is there anything that can be done to make that easier for staff? Thank you.
Yeah, thanks very much. I think I'll bring Stuart in, if I may, on this one. Thanks, Stuart.
Yeah, thanks very much, Carol. I was going to quote the figure later on in the performance report, but I'll do it now, Ronnie, as you've asked the question about staff. So the current uptake rate as of last week for staff in Powys is 54%. That's probably middle of the pack for Wales at the moment. So uptake for staff flu vaccination, and this is obviously for frontline staff, is probably lower than it would have been otherwise, because of the Omicron wave effectively has disrupted it. But we're at 54% currently, and we're sort of middle of the pack compared to other health boards. In terms of your question about where we are in terms of going forwards, there absolutely is still the offer of flu vaccination. We've delivered it through 2 routes this year. We've done a peer vaccination programme where we've effectively trained staff on wards and in service areas to deliver flu vaccination to their colleagues, as well as we've been fortunate enough to use a number of clinical educators actually to do flu sessions, as well as bespoke clinics where people can drop in. We had a meeting on Tuesday just to, we meet every week to talk about the staff flu programme. What we did on Tuesday was we had a little bit of a closer look at the data now about uptake in different service areas. So we've done some analysis of uptake on our wards and in different service groups. We're really trying to make a more targeted offer now as we go into January and February. So there's a number of wards where relatively uptake looks a bit lower than some of the others. So we've agreed this week, as just an example, where we're reaching out to the peer vaccinators on those wards just to try and get a bit more insight about what's going on, but also in terms of how we might continue to make that offer, particularly in those ward environments, whether it's about the days we offer the vaccine or how we target particular staff on the ward that haven't come forward for vaccine in terms of the offer. We're exploring that at the moment, but the programme does continue, and we're probably, it's fair to say, taking a more targeted approach now just to pick up those staff that haven't yet come forward and try and understand and give a more tailored offer.
Thank you.
Are there any questions? No? Well, that just leaves me to thank you very much for that excellent presentation. Very concise, but nevertheless covering a lot of ground. So I'm grateful to you. Thank you. The next item is the integrated performance overview for December 2021, after which I hope that we can have, and this is an incentive to Hayley to present the headlines as succinctly as possible. I hope to have a short comfort break. So over to you, Hayley.
Diolch, Cadeirydd, am y cyfle i gyflwyno'r adroddiad perfformiad diweddaraf i'r bwrdd. Thank you, Chair, for the opportunity to present this high-level summary of the performance position against the National Delivery Framework. This report has come directly to board today as the Delivery and Performance Committee meeting in December did not take place. This report has been developed by the performance team into a revised format, we start with an integrated performance dashboard summary first, then a more detailed narrative against key areas, and again would welcome really any feedback from board members around the revised approach and how we can strengthen it further. We have already discussed quite a few elements in the system resilience presentation of performance, which I wasn't going to cover again and have an opportunity for questions, but just wanted to pick up the impact of the system resilience, urgent care and scheduled care, emergency care access issues. Particularly, there's a direct correlation between the system pressures we've just discussed with the ability of our commission providers to undertake planned care activity. So just thought I'd start by just highlighting the planned care position still shows a significant backlog of people awaiting treatment, and again expectation that this will take several years to recover the position. But as at November in the report, we've now got 4,381 patients waiting over 36 weeks for treatment. As a commissioner across Welsh and English providers, it's been an extremely challenging time for our acute providers, with a number of them at the highest levels of escalation over the last few months. But hopefully when the urgent care pressures start to alleviate, capacity around planned care will start to improve. Our Welsh providers have currently, that we commission, 487 patients awaiting more than 104 weeks for treatment, with 35 patients remaining above 104 weeks in our English commissioned services. Key specialties of concern remain the same as before in terms of the volume of people waiting, and that's trauma and orthopaedics, ophthalmology and general surgery as well. And I'm sure Kate might have a chance to come in a little bit on cancer later. Just want to focus a little bit, building on the previous discussion that we've had around, as a provider, what we've been doing around planned care. So I'm really pleased that the team again are working tirelessly on the first point, which is for those patients waiting for a new outpatient appointment, I'm pleased to be able to report to the board we've now cleared the backlog and we have no patients waiting over 52 weeks, and that was achieved by the end of December for a first outpatient appointment. And we have nearly reached achieving no patients waiting over 36 weeks. We've only currently got 24 patients waiting more than 36 weeks for their first outpatient appointment. So this is really excellent progress on that factor. In the report, it's highlighted that we've had a reporting system issue around our follow-up data, which is not contained in the integrated performance report today. Very sorry about that, members, but we're still working through and understanding what the root cause of that issue is, and we will bring a detailed report to the Delivery and Performance Committee next month on what happened. An updated performance position around follow-up data, and also making sure that we can give you assurance that that issue has now been resolved. So I just wanted to highlight that. Diagnostic performance continues to have a strong focus. We've had 184 patients waiting longer than 8 weeks for a diagnostic. Key areas there are around endoscopy, cardiology and non-obstetric ultrasound. Just the main numbers are in endoscopy. It is still fragile due to staffing absence challenges, but just again wanted to reassure in terms of the urgent suspected cancers, we're up to date with those. We have a trainee endoscopist for gastro capacity who will qualify in June later this year. We've got a really strong clinical review process, and we have now addressed the two issues in the report. A new endoscopy reporting system will be in place by the end of February, which will be really important to maintain our JAG accreditation, and also the insourcing capacity that Carol mentioned coming online as well in February, which we will have an improving picture. Just thought I'd mention there, the regional work on endoscopy is also a key area of focus for us to make sure that we're tied into those regional solutions. Therapy performance, again, we have 42 patients waiting more than 14 weeks for a specified therapy. Those two areas are audiology and physio. So again, some targeted work to work on that. And then the position for us in terms of our patients waiting longer than 52 weeks in Powys as a provider, we currently have 227. Which was in September. I reported the position in September as 227. We've now reduced this to 73 patients in January, and we continue to ensure that the insourcing solution will further get us nearer to recovering the over 52-week backlog that we've got. We have had some fragility as well around in-reach anaesthetic sessions and shortfalls in some of the in-reach during December and capacity due to the urgent care system pressures. So I just wanted to give a general picture around planned care as a provider. We're doing okay, we're making really steady, good progress in the right direction, and we'll continue to move forward with that. And again, final point on that is the November position, when in the report shows there were 83.9% of patients are waiting less than 26 weeks for treatment. Again, we're now, this in January, we're at 84.4%, so we're gradually going in the right direction. But if I could ask a couple of exec colleagues just to come in to highlight a couple of other areas, if that's okay. Could I ask Stuart, is there anything on the public health measures you wanted to pick up, recognising the flu and a couple of the other areas have already been picked up?
Yeah, thanks, Hayley. I'll just cover off those briefly if I can. The first thing just to note in relation to just a COVID is just to record really. Obviously, now we have both PCR and lateral flow testing, increasingly just relying on PCR data to give us an accurate count of cases while we still continue to do that will become less robust. So just to note really, we're doing a piece of work at the moment to look at how we bring lateral flow test results through to the performance reporting as well, and our surveillance more generally. So I would expect to have a slightly different reporting of cases as we go forward, as we look to bring in lateral flow tests going forward. Just in terms of a couple of other performance items, I picked up staff flu uptake already. If I could just briefly summarise where we are with over 65s and then under 65s at risk. So for over 65s, the current figures as of second week of January, we're at 74.9% uptake for 65 plus. That's pretty close to the 75% target that is set each year for uptake among 65 plus year olds, and that's actually an improvement of where we were at year end last year. So we have seen good uptake relatively of flu vaccination for 65 plus year olds compared to last year, and against target we will, I suspect, probably this week or next week hit that 75% and hopefully move above by end of the flu season. For under 65s at risk, the rate is lower, and it is every year slightly lower for under 65s at risk. So we're currently at about just under 49% uptake for under 65s at risk. That's above the Wales average at present, and on a health board level basis, we're second highest health board currently for uptake among under 65s at risk. So noting that it is below the target that we set ourselves each year on an all Wales basis, relatively uptake for that cohort is good for Powys, but we're obviously continuing with the offer of vaccination through general practice and pharmacy to try and continue to encourage that cohort to come through for vaccination. So that's just a quick summary of flu. And then just the only other area just to note briefly, slide 5, just around alcohol attributable admissions to hospital. Just to note that we have seen a quarter by quarter reduction in admissions, which is positive. So the admissions between Q1 and Q2 did go down. There is a target for all health boards to demonstrate a consistent reduction over 4 sequential quarters. So we need to see how that plays through, I think, into Q3 and then obviously beyond to see whether that's sustained. We also have to note, and it is covered in that report, just the impact of COVID, particularly in terms of alcohol use. So there is some research from Public Health England that demonstrates increased use of alcohol during the pandemic. So it's just to note really that is a challenging target for us to deliver on, and I think it will probably continue to be challenging as we move through into Q3 and Q4 this year, really given the impact of the pandemic and the way in which it's manifest through a lot of other public health measures other than just case incidents. That's it. Thanks, Hilly.
Thank you, Stuart. We're going to go on to Pete now, if that's okay. Any issues you would like to highlight, Pete?
Yeah, thank you, Hayley. So I'll just give a couple of overview highlighted key issues, and we can pick up any questions on the end. I guess the first one in relation to GP in-hours access standards. It's pleasing to note the improved performance now up to 93.8%, particularly given the current system pressures, which we've been hearing all about all morning. I guess the challenging area for us is in relation to dental access for both adults and for children. And just to note the requirement for all practices to offer 2 additional places to people on a weekly basis. That's being closely monitored to help improve that access. We're also looking to increase capacity in the mid of the county, which will also help. And I guess the other one to flag is the ongoing, continuing strong performance in relation to out of hours, which is pleasing to see maintained given the current service pressures. That's it for me, Hayley, and happy pick up on any questions when we following going through it.
Thank you, Pete. We're not going to come to Claire because there's a separate report on mental health, but Alison, would you like to highlight any areas?
Oh, diolch, Hayley. Thanks very much indeed. I wonder if I could identify, please, the colleagues on slide 43, our progress in terms of neurodevelopmental assessment. You'll see that whilst we're performing favourably in terms of the All Wales average, we still remain below target, and to provide some assurance about the heavy focus and ongoing work within the service to revise pathways, make sure that we maximise our opportunity to streamline that access to assessment and outcomes so that we can improve our performance in that area. In particular, we're looking to strengthen multidisciplinary teamwork in there, and there's a whole team response to that. If I can also ask colleagues to visit slide 49, where one element of quality is measured, and articulated, and you'll see that we've maintained our steady progress over the last 12 months, and we've now got a 62% response rate to concerns and complaints within the 30-day time frame. Colleagues will know that's a month-on-month improvement. We still don't compare favourably at an All Wales level, but please bear in mind we contribute to the All Wales score, so as our performance improves, we won't see us moving up the ranking until we tip over into our target performance arena. Diolch.
Thank you, Alison. Kate, would you like to come in?
Thank you. So just to give a couple of headlines on where we are with the cancer services, then I think of note then the numbers of referrals into our provider service for diagnosis and investigation has risen during the later parts to pre-pandemic levels during the later parts of last year. So there is evidence that the demand is increasing. Our main tool for monitoring our cancer services on a national level is a single cancer pathway, which you'll remember is the target of having the first treatment started within 62 days of first presenting. So we have information from all our neighbouring health boards and provider health boards around that. You'll see from the table that overall in our Welsh providers, and the situation is fairly stable. For our English providers, again, we getting the numbers through and they're fairly stable. The headlines for some of the reasons for delays are access to radiology, access to elective surgery, and other factors like patient choice. Positively, then, as part of our renewals programme, we are now more actively tracking our cancer pathways. So we will receive information on the cancer breaches from our surrounding health boards, and we're now starting to look much more closely at what's happening. That is going to give us really useful information and help us design and develop our pathways to be better as we move forwards. At the moment, we're only receiving information at the end of the pathway, and we are seeking to have more open access so that we can track the pathways as they continue, which will give us more valuable and rich live learning as we go forward. So overall, increased demand, evidence of that, a fairly stable position in terms of breaches, which we'll obviously monitor very closely over the coming period, as we've just been through a very, very difficult position in terms of the acute sites nationally. Thanks very much.
Thank you, Kate. And by no means least, Julie, just the general position of any issues around the workforce, or anything else you want to cover? Thanks.
Well, I think we've already touched on staff sickness, and in the performance report we were reporting in November, we know that number has risen by over 1% during December, and we recognise that there has been an increasing pressure on our occupational health services, for which we are reviewing how we address that. So I think it's important just to note that. Despite the things that we've already discussed so far, we have been able to maintain our performance in terms of PADR at 75%, recognising that's not hitting the 85%, but that by no means is a underachievement in the pressures that staff have been facing. So that focus has remained on PADR compliance. And then I think just to mention, there is a measure which relates to staff engagement. The data that's recorded relates back to the staff survey. We will be having a new staff survey this year, but just to say to board, we have continued to review locally staff engagement, particularly in light of agile working.
Thank you, Chair. Thank you, Julie, and thank you, Chair. Sorry to there's a lot to pack in this performance report, and I thought it was really important for us to give an overview around some of those key highlights. So happy to take any questions from you.
Right, I can see Robert has a question.
Yes, thank you for that. And I quite like the format. Actually, you've got the right balance there between overwhelming detail and you know, just too little. I've got two questions really. The first one is quite a delicate one really, because I would like to be reassured that the reduction in in-reach activity is proportionate to the pressures, bearing in mind that people who are coming from other health boards, you know, will often be part and parcel of separate waiting lists in their own domains. And the second question is really a suggestion. You know, we obviously spend huge amount of money on commission services, and I'd be interested to know how those other health boards and trusts are desperately trying, to speed up the treatment, elective surgeries, and so on. I haven't seen much information on that. I appreciate that it's, the way they do it is, chiefly going to be part of their plans. But at some stage, I would like to just see some of the headline ideas which they're trying to use to desperately reduce these waiting lists, which are affecting so many people in such a terrible way. Thank you.
Yeah, thank you. Really important points. I'll have a go, and then I think Carol might want to come in as well. But just in terms of the first point, I think it is proportionate. So it's partly to do with staff absence. So sessions have been cancelled due to their inability to come for staff sickness and other reasons. And also, for example, 2 organisations, Cwmtaf, Morgannwg and Wye Valley Trust, had to step away from sessions to send anaesthetists, and as you can imagine, critical care capacity was under pressure as well. So I do feel it is proportionate. It's delicate. I appreciate that, partly because the fragility, we do feel the pressure that the acute sites have, and they have to manage risk as we do. But I do feel it's appropriate and proportionate to the pressures that we have had during December and January. I think it does pose a question for us about how do we have a more sustainable and a less fragile approach to this moving forward. And I know that we're planning under the renewal work to look at that more carefully over the next few months. But I do feel it's proportionate. But the key areas were around staff absence, and also it was particularly anaesthetists. And then the second point around commission services is that we do have an awful lot of information that's shared through our contract quality performance review meetings around the work that the health boards are doing. There's a direct correlation with the emergency pressures and their ability to be able to protect what they describe as green capacity for elective care in the acute sites. Part of the reason our planned care performance can manage reasonably well is we don't have that tension in our system as a provider to manage in the same way as the other health boards have, but also partly because in terms of the IMTP, we will be ensuring that we'll be looking at what arrangements and what systems and processes people have been putting in place. And we get a lot of that sharing through the National Planned Care Programme. We know what other health boards are doing, and it may be about sightedness of that information, Robert. We could probably provide more information through to perhaps a DMP committee on some of those aspects for you. But I know people are working extremely hard to try and protect elective capacity, and there will be some urgent service changes that the other health boards have had to do to protect elective capacity. An example, several examples that come to my mind that I've been in discussion with CHC with earlier this week around consolidating services around fracture clinics, etc., in certain locations in order to maintain that green capacity. So generally, though, if you feel you need more information on that, we can work on that together at a committee meeting. But Carol, would you like to come in and add further?
Yeah, thanks very much. A really important question, Robert, given that so many people who reside in Powys actually have sort of secondary care interventions at hospitals outside with our partners. So just yesterday, the NHS Wales Leadership Board considered the issue of planned care. We noted in particular really quite strong performance in November, although when the data was published last week, it perhaps didn't sort of come through quite as well. But there was a theme of important and strong recovery during November to a place of just under 0.5% of activity short of the sort of pre-pandemic levels for some of the steps of the pathway. That will have been knocked absolutely during December and January. We know that some partner organisations have had to implement temporarily some parts of the local options framework because of the urgent and emergency pressures and because of the Omicron wave affecting staff absence. So we are expecting at an All Wales level the data to look worse for December. So yesterday the discussion and the clear focus on analysing the current data on the waiting lists and health board by health board and trust by health trust analysis. Now I'd contest that most health boards and trusts will already be across their data as we are. That a variation and opportunity analysis takes place. So what are the specialties which lend themselves to us being able to accelerate more quickly, and which are the specialties that are more difficult? We know that even pre-pandemic there were those specialties where there were greater delays. And then through February, there will be focused action planning meetings between individual organisations and Welsh Government to support a national operational recovery plan going forward. So if members of the public are watching this board meeting, well, but I think, you know, many people will be focused on when will I get my planned care? And so we should be in a position to be clearer about those pathways where we hope to be able to accelerate, those that are more difficult. And of course, as Hayley mentioned earlier, the renewal programme also picks up the ability to offer advice and support to people who are waiting on a waiting list. So a lot going on in this area. I'd envisage us spending more time as a board on the recovery and the trajectories and what they look like, particularly as part of the IMTP. Thank you. Thanks, Chair. Thanks, Hayley.
Thank you. That was very helpful, actually, because it is certain that people will be waiting anxiously, won't they, to know. If there are no more questions, perhaps we could break now very briefly for a comfort break. That information was very informative, very helpful. We can keep it with us and look forward to seeing improved performance now as the months go on. So yes, a short break. Shall we say that we resume at 11:45, please? Thank you. Hey. Welcome back, everyone. We'd like to proceed as efficiently as possible with the next part of the agenda. And the next item 3.3, is very important, the Mental Health Partnership Annual Report and Renewal Priorities. So I'll hand over to Claire Madsden, who I think will introduce Joy Garfitt.
Thank you. Thank you, Chair. Yes, this next paper is a paper for information, and it's the annual report, and it will just focus on how Powys has performed against the actions and milestones in the Welsh Government's Together for Mental Health delivery plan. So I'm just going to hand over to Joy Garfitt, who's our Assistant Director of Mental Health Services and Learning Disabilities, who will take you through some of the details. So thank you, Joy.
Good morning, board members and colleagues. Prior to the COVID-19 pandemic, Welsh Government required all mental health planning and development partnerships to prepare an annual plan. This requirement was suspended during the pandemic. However, our Engaged Change group, comprising of service users and mental health workers, wished to prepare an annual report for 2021 in order to promote the development of the service that we've achieved during the most testing of times. And I'm exceptionally proud of their and our team's work during this time. While this report reflects 2021 and activity, this work has also continued into this financial year. And areas I'd like to just highlight for members' consideration are the harm reduction work and suicide prevention work, and the development of a pathway to support people affected by suicide. And members might be interested to note that for every one suicide, we forecast and research forecast that around 150 people are affected by each suicide in terms of people being known to them. And that work to support people bereaved by suicide has continued into this financial year. And I'm pleased to report that it's being co-produced by people with lived experience who have helped us tailor our services. In terms of CAMS development, the early help hubs and emotional health and wellbeing support based within schools has moved from strength to strength, and I'm very pleased to report we've just received confirmation of another 2 years funding for this essential work. In terms of Silver Cloud, our online CBT work, Powys hosts this for the rest of Wales, and it comprises of interventions such as anxiety, depression, stress, money worries, and a whole multitude of modules for long-term conditions. It's very much aimed at helping people to help themselves and support their own recovery. And Welsh Government have just awarded us £4 million in funding to continue this service for a further 3 years on behalf of Wales. And not to forget, within 2021, we commenced our new early intervention in psychosis service. We know that psychotic illnesses generally develop in later teenage years up to about the age of 35, and we've developed a through-age service to better support and identify younger people living with experiencing their first episodes in psychosis, to make sure they receive treatment in a very timely manner to maximise the best opportunities for them, as well as our perinatal mental health services that commenced in 2020, and we've built on these year by year. Those are just a few of the areas which the report raises, and if you have any questions, I'm very happy to take them.
Thank you, Joy. I would say visually the report is lovely, beautifully clear, and it's illustrated very well, so it's really good to look at. Thank you, and thank you for your presentation. Are there any questions for Joy, please? Ronnie?
Thank you. I too thought this report was set out in a very clear and helpful way, and I'm grateful for that. I had one question about CAMS provision and the age-appropriate bed at the Lindra ward in Bronclease. Is one bed sufficient for that purpose? That was my first question. And my second question really relates to information that's further on within the board papers, which would suggest that that there is a reliance on locum cover for certain aspects of mental health care and provision. And it seems to me that in relation to mental health, there's quite often a need for a client to build up a close professional relationship with a particular clinician over a period of time. And the use of locum cover, whilst it's very necessary and very appropriate in the circumstances, may be potentially disruptive to that situation. So I just wondered if you could comment on that, please.
Oh, thank you, Ronnie. So first of all, in terms of CAMHS and the age appropriate bed, this is something we'd rather not have. We've had to develop this in line with the other Welsh Health Boards because of delays getting children and young people into what we call Tier 4 beds. There are 2 of these in Wales, one in Abergele, run by Betty Cadwaladr, one in Bridgend, run by Cwmtaf, and there is often a delay of 42 to 72 hours while those 2 units come out to assess a young person. Unfortunately, frequently there's issues of capacity in both of them, and there have been delays. On average, we have about 1 to 2 young people a year using the bed. And please, members, don't think of it as just a bed in a room, which I don't use the rest of the time. The bed moves around, as it were, depending on the number of patients we have requiring this service. So it's a flexible provision which we use when there's no alternative, and we explore every other alternative than to treat a young person on an adult ward, which is what we don't want to do. So it's been developed because of on a needs must basis, and we continue to review that. So I hope that answers that question. And the second part, use of locums. This is particularly in terms of consultant psychiatrists. There's a great shortage across the UK of consultant psychiatrists, and it's a very competitive market to try and encourage people to come and practice in a rural area such as Powys. As a service, we've done quite a lot of work working with executive colleagues on this, and there's a paper going through executives hopefully in the next few weeks to look at a different approach to a recruitment campaign. And Ronnie, just in terms of patients, in terms of your question, patients prefer consistency in clinicians treating them, and we support that. And it's just to add that the vast majority of our patients have a whole multidisciplinary team built around them, especially those in secondary care. So the nurses, social workers, OTs, etc., psychologists who are supporting the individual will, in the vast majority of cases, be very consistent. The MDT will be consistent around the person. It's the psychiatrist element which has been a real challenge for us, and recruiting substantive psychiatrists to Powys is my number one objective really for the next few months, because it's proving to be, quite frankly, quite a stressful area, and we've had a number of locums coming through our system and leaving us, which is not a situation I want to be in.
Thank you. That's a very important question, actually. Carol, I think you wanted to come in at one point.
Yeah, yes, please. Thanks very much. And it was back in 2012 that this partnership was established. And there are partnerships in each of the health board areas, and of course this now links more formally into the regional partnership board as well. So I've just seen this go from strength to strength, so it is the 10th anniversary coming up now later this year of this partnership being established. I wanted to draw out a comment particularly on the level of co-production, the level of joint ownership of this agenda with people who have real life experience of mental health issues, emotional health issues, and actually the broadening of the agenda, not around serious mental illness, but much more to the emotional health and well-being. That is not just the domain of the health service, though, and I just wanted to stress that that is a much broader issue for us, be that local government, third sector businesses, etc., and communities themselves. So I think there is probably still some work for us to do in ensuring that that sort of gets embedded in general life. And I know that our colleagues in the police service, fire and rescue, etc., are attuned to that as well. I did want to pull out a couple of comments in relation to Ronnie's question, though. Joy is absolutely right. We really should be striving not to have an age-appropriate bed, and the day that we don't need one will be a day to celebrate, I think. But the demands and the challenge of provision at that inpatient level is really quite difficult to shift. And progress had been made, and I think, you know, it's fragile progress. It is under pressure. We're involved in that obviously through WISC, the Welsh Health Specialised Services Committee. So that has got to be an area where we maintain. But of course, we need to work through the whole of the spectrum of support and intervention, from universal services right through to more targeted. And we've got the NEST NICE framework, which is really bringing agencies together to support at a much earlier stage. And then finally, on the workforce element, Health, Education and Improvement Wales will be publishing for consultation a workforce plan related to mental health very shortly. It is the first plan that falls from the strategy, the overall strategy that was approved last year. And that's because it reflects how important the issue of recruitment, training, retention is in mental health services. So we're not alone. I suspect we're going to have a very hard look at how we configure our services to make the best use of the expertise that's available to us. So that is a priority for us that's going to get into the IMTP as well. But I want to just commend the report and say I thought it was great. The fact that it is absolutely produced by people with the lived experience of mental illness and emotional health issues was fantastic.
Yes, I agree, and the future priorities, very, very important. Trish, you've got a question.
Yes, it's really the future priorities that I'd like to pick up with Joy. But I also commend the report. It's amazing. So I was particularly interested in the next steps relating to the development of physical health metrics for people with mental health, but also the establishment of carers forums. And I wonder if you could say a bit more about that, and whether what plans we have. Have we got milestones? What's the time frame for actually taking these forward?
Certainly, thank you, Trish. So we know that people who live with serious mental illness die far younger than the rest of the population, which is nothing but a tragedy. And we're absolutely committed to improving the health, physical health and well-being of our people who live with serious mental illness. We're just starting what might be the start of a very exciting development. So we've just recruited a GP to work within our mental health services to focus on the physical health of our patients, and to make better links between primary care in terms of GPs and the secondary care in terms of psychiatry and mental health services. So that the job plan is looking very exciting for that individual who we've just appointed, and he will start on the 1st of March. And we're hoping that this will lead us very much into how we can develop this right across the county. So Trish, I'll be very happy to give you updates on how that work plan goes as we move on. We encourage all of our patients to attend GP at least once a year for physical health checks. Harm reduction is at the key of everything we do in terms of mental health, and where there's coexisting mental health and substance misuse, which is quite a large group of overlap in our patients. Smoking cessation, I can never say that word, giving up smoking is absolutely key and a priority. and we're moving in this next year to the ban on inpatient smoking, and how we're going to manage that in terms of replacements for nicotine will be a challenge, but we continue to work with our patients on healthier lifestyles. We're making much more in terms of our community psychiatric nurses in physical health checks when we get patients in, doing routine observations, and we're especially for those patients who are very reluctant to attend GP, and we have quite a cohort who don't tend to touch other NHS screening services unless they absolutely have to. So what I'm trying to say is we're trying to link up the whole of the physical and mental health care system, which is wrapped around each individual, to make sure that a group of patients who don't regularly attend screening or have promotion work, that they're better linked to it. And we also have a huge range of, within our CMHTs, service user-led exercise programs, walking and talking. Just to raise examples of, we have a group of men's mental health in North Powys, 2 groups, one around walking and talking football, one around walking and talking rugby. We're really keen to get that extended right across the county. So combating both isolation, loneliness and men not being willing to talk or more reticent to talk than women, and as well as health and exercise. I'm not sure, Trish, does that answer your question?
I suppose it was more about actually concrete plans and milestones and when we're going to see this, and but it's really interesting to know. My other question was about a carers forum, and is that established, or when is it likely to be established?
Okay, in terms of carers, we work with CREDI and other carers organisations, including Alzheimer's dementia groups. There isn't one forum we work with. So we work with a number of forums to listen to the voice of carers and build carers' views into our service development. In terms of our co-production work, it's not just people with lived experience themselves who are helping us develop and design services, but it's also carers from each of the various elements, whether it's eating disorder, particularly in younger people, whether it's dementia, predominantly in older adults. There are carers reps as well as people living with those conditions who help us design our services. So in mental health, we've taken the point of view that we don't do any service development or any service redesign without using people with lived experience or people who care for them. And that's how we seek to make sure that services are robust and respond to people's needs.
Thank you, that's lovely. Thanks, Joy.
Well, many thanks, Joy, for that presentation. Great to see the progress and future plans. Many thanks. Can we move on then with the agenda, please? Handing over to Pete to tell us about the financial performance in month 9.
Thank you, Chair. So the finance report is included in the papers in the usual format. As always, I'll take you through some key issues and we can pick up on any questions at the end. As I go through, I'll reference the page number from the financial report. So first of all, on page 2, as of month 9, the Health Board against revenue is £134,000 underspent. We continue to hold our forecast of break even. That delivery of a break even position is subject to the ongoing appropriate management of risks and opportunities as needed for the plan. In relation to our capital resource limit, which is currently 15.2 million, we've currently spent 3.8 million to date. But there's a significant level of commitments and work in progress that give us confidence that we'll deliver a break-even position against our capital position too. If I just take you on to page 6 and 7, this is a consistent theme that I've been highlighting to the board in recent months. Our key cost pressures within our financial position relate to variable pay, where we've seen a significant increase in those cost pressures. That will be partly related to the pandemic and all the ongoing associated issues with that. This is an area that's been constantly flagged in recent months. The second key area is in relation to our complex care and our CHC packages of care. The reason I flag these two areas is they'll be key that we manage these as effectively as possible as we move into the new financial year, because this will have a significant impact on our financial plan and our planning in the IMTP for the next financial year and the 2 years after that. The other two areas to highlight in relation to that are our current block arrangements in relation to our LTAs and our ongoing significant spend in relation to prescribing. On page 8, I can just highlight our total forecast spend in relation to direct and indirect costs of COVID of 32.88 million. Just to confirm to the board that that expenditure is covered by relevant funding as is included in our financial position. Next area to highlight is on page 10. This is tracking our current underlying deficit. This is an area that has been highlighted to committees and board in all previous meetings. Currently moving into the new financial year, we're looking at a net opening plan deficit of 9.5 million. As a reminder, that's made up of brought forward and achieved savings from the previous 2 years as a result of the pandemic, and the in-year cost pressures that I've just described, mainly in relation to variable pay and continuing healthcare. Well, there's some other components included in the table there. What I will just reference is that as part of our allocation letter for the next financial year, which greatly influences our financial planning as part of our IMTP, there are some positive messages in there where we've received a 2.8% uplift, which is higher than in previous years' uplift of 2%, and the wage award will be funded outside of this uplift. That means this gives us some ability to cover this opening plan deficit as is brought forward. There will be financial challenges within our plan, and we're working through those challenges in the final financial plan as part of the IMTP work, which has been previously referenced in the meeting. And I think they were the key issues I just wanted to get across. As always, happy to take any questions, Chair.
Yes, thank you, Pete. I can see that Mark Taylor, independent member, has a question.
Thank you, Chair. Yeah, commend you again, Pete, in terms of the presentation and clarity of the report. I suppose question for me is, after saying well done in terms of the team for achieving a balance over the last 3 years, is just concern around the deficit which is accumulating and the potential for that affecting us in terms of our ambitious programme going forward. So I think you put some positives around the settlement, but the other sort of message I received is the settlement in some areas is perhaps tighter than expected, and it's really how we're going to sort of deal with that. I know we've got the IMTP planning process, etc., but I think it's just given us a sort of overview of where we are now in terms of how much of an obstacle or anchor that's going to be against our future.
Apologies, sorry, I put myself on mute. Thank you, Mark. It's a really important question, and I probably won't be able to give the full detail in my response, the full coverage it deserves, and we can get into those details in the relevant committees and other board sessions. We're doing that detail and working through in terms of our IMTP. At the moment, what we can include in our plan and what we exclude, we can only include the things that we know about. As I said, there is some positive news in there in terms of some cover for our brought forward deficit. And I think really the key message I will give, I can't really answer whether how much of a barrier or opportunity it will be, but the key message for me is that we continue with our value-based healthcare approach, and we continue with allocating our resource, our money and our people to those areas which will deliver the best outcomes for the population. That approach has been our approach over the last year and continues to be, and in that way we will organise ourselves in the best possible way to deliver against our priorities. I know that's a bit of a general statement, but that will form the basis of how we develop the plan, and we can pick up on some of those further details as it progresses. I hope that's okay.
Yeah, Carol, would you like to comment on this?
Yeah, thanks very much. And Mark, quite right as well, that our attention and our focus is turning to the new financial year and the 3 years ahead. particularly when we reflect on today's agenda. We've talked about system resilience, the need to maintain service provision, as well as then some of the challenges around backlog. Just that item that we've had on mental health flags the workforce challenges, etc. And all of that, I think, leads us to really trying to focus on how we best spend the money that we've got allocated. You know, we're a £340 million organisation. That is truly significant amount of resource to be able to spend to improve health and well-being for the Powys population. So our thrust is going to have to be on value, on outcomes, experience and cost. I think if we can use that as a guiding principle, we'll need to be getting into those areas where we think there is most to gain in terms of pushing pretty hard on that. And that's some of our renewal programme priorities as well. I'm looking forward to us just moving now through February and March, being able to engage more broadly on what that means in the reality. The areas we really will focus on and try to get a lot of energy and effort behind. But I think we also have to be open and honest with everyone about the limitations that we will have. Some of that will be around workforce. Often it's not always about money. It's about, can we get the right resource and expertise to drive forward the things we need to. But we will have to very clearly lay out some of the choices that we may have to make should the resourcing be extremely tight. So I think we've got a board development session in February. We usually try to manage to have some stakeholder discussions as well through February and early March. And then at the March meeting, we'll be able to unpack this in a bit more detail.
Thank you. Happy with that response, Mark?
Yes, thank you, Chair. I just wanted to flag it up and just start there as a conversation in terms of as Pete and Carol have picked up. So thank you very much.
Thank you. And, you know, inevitably things are going to be a bit difficult across the whole of Wales, aren't they, following the pandemic? So thank you, Carol. Can we move on then, please? If everyone is happy with that, we have the information, we can dip back into it as we want to. Could we go on, please, to talk about the corporate risk register? And James Quance, our interim board secretary, informs me this has been reviewed and updated by the executive committee. So James, over to you.
Thank you, Chair. Yes, the corporate risk register at January 22 has been updated following the established process of review within managed groups and the exec committee. Changes to the register are highlighted in red as per the convention. Focus has really been on updates reflecting the pressures within the system currently and the exec committee's view of the impact of them on the risk profile of the organisation, which we have seen the themes from Carol's presentation. There's no new risks escalated to the register. However, 2 risks of an increased score from 12 to 16 in respect of sustaining an adequate workforce and potential adverse impact on business continuity and service delivery arising from COVID-19. In terms of the latter, there's a number of actions included in there now which highlight the risk that is being managed through the command structure. It's also proposed that 2 risks, CRR 16 in respect of health and safety and CRR 17 in respect of fire safety, are de-escalated for continuing monitoring through the relevant management groups as a result of actions that have been taken to mitigate risk, including the implementation of internal audit recommendations as reported to the Audit, Risk and Assurance Committee. But there will need to be an ongoing programme of assurance with regard to those areas and to ensure compliance, and then we'll need to make sure that the level of oversight remains appropriate. So I'd invite the board to review and comment on the risk register and discuss the appetite, threshold and tolerance levels for each risk, but may need to defer to individual lead execs for specific risks.
Thank you, James. Mark Taylor, question?
Thank you, Chair. It's a specific and a general, if I could. general is around the health and safety risk, in terms of, just as a step back from myself, it surprises me as an organisation of our size and complexity that we won't have anything on the corporate risk register in terms of that particular area. So I suppose it's just, well, is that actually, I don't think it's a negative, but it's just, is it real in terms of where we are? And just a question around that. And the second one is more specific around fire safety, and acknowledging the good and positive work that's been done around policy and the actual site management aspects. It's just a slight difficulty for me in terms of de-escalating that risk without seeing perhaps some of the more specific information that the executive may have considered in terms of audits and how that policy is actually bedded in. So I've got no problem with the de-escalation, but it's just that underpinning information to be assured on that point. Thank you.
Thank you. Can we, I don't know how we're going to deal with that. Is it Jamie?
Yes, I think Carol was whispering Jamie then. Hi, Chair, jump in. I guess, thanks, Mark, thanks for that question. Obviously, I'm speaking now with my new role on. So there are 3 risks on the register as it stands. CRR 5, which is related to estate, which is now within my portfolio. CRR 16 and 17, both again within my portfolio. As executive team, we reviewed them all, of course, as we do within our processes. If I just answer on 5 as well, even though you didn't ask a question, Mark, because there is an overlap. I think 5 is clearly an estate risk and remains and will remain, because it's an issue for board at all times, particularly bearing in mind our aged estate in Powys, both in terms of the lack of recent developments, but also as in the last 15 years or so compared to most of the health boards, but also our particularly aged estate, some of which predates NHS creation. So that risk remains on there and will do so. We will need to review that anyhow, Mark. Fire risk and compartmentation, a word I always struggle with because it's too many syllables, is actually within that and it's covered in that as part of our wider risk around estates. But post the production of this risk report coming in, we've had notification about some changes to our discretionary allocation from Welsh Government for next year, and also potential risk around EFAB funding, the State Funding Advisory Board, which has been Powys and other health boards have been a huge beneficiary of. So we'll be actively reviewing the capital plan for 22-23 as a consequence of that, which will inform our review of that risk as well. But I wanted to be clear to colleagues that fire risk around estate is within that, along with all of the risks. Our assessment of risks around estate are always risk-based by default. So I answered that question, Mark, in fairness, and I'll pick up with you offline in some more detail. Of course, I always welcome your view on the matters, as with other independent members. As for health and safety, I think I hear your question, and the way you phrased it, Mark, makes it slightly easier to answer, which is some of the detail behind that. I think the particular starting point was, is it appropriate for health and safety not to be at a board risk register? Now, I'm not going to be the guru across the whole of Wales, but my recollection was this was raised to the board last year, and prior to that was not on it. So I think it does suggest that things can go up and down accordingly. There were particular issues on health and safety, the lack of a policy, which is a board action to approve. So it goes back to who is owning the risk and managing that risk on a daily basis. And I think the work around reviewing risk assessments, the signing off by the board in November around the policy, but also the corporate, as we call it, health and safety plan at the end for the rest of this year was in that and drove that. There is more work to be done. Health and safety is a continual dialogue with every member of staff because everyone is responsible for that. But it goes back to ownership at a board level. My request, along with executive colleagues, was that we will continue to review this in the health and safety group that I now chair and consider that. The key action for me now is the deployment of that policy and the detailed training needs assessment to ensure that we are clear about exactly which members of staff require which levels of additional training above the statutory mandatory that we all do. Yeah, and we get that work to executive team in the coming weeks and onwards. As for the fire one, as I said, I think a lot of excellent work on the policy and the process issues related to that, which is why it was raised in the first place, Mark. And I can confirm that over 400 staff have been trained in the last 3 to 4 months on fire drills. and I can report today that every hospital site, which is our higher risks, albeit they are different to perhaps a DGH aspect, has had a drill both in daytime and nighttime. In this current cycle of normal reporting periods, as in the last year, so they're compliant, with this sole exception of Brontlease that was booked. We had a COVID outbreak on the ward, we had to stop that drill. That'll be booked in the coming few days when we get confirmation that we can do so. So I think there's a dramatic improvement. That's the context behind it, Mark. Sorry, Chair and Carol, that was a long reply, but hopefully I think it shows the importance we take in this, but it will be continually monitored. And of course, the new portfolio that I'm delighted to be holding for the Health Board links capital, fire, health and safety, and many other aspects all together. So there's a natural overlap within this concrete portfolio now going forward.
Well, thank you, Jamie. Mark, do you have a follow-up question, or are you happy with that for now?
Yeah, thank you, Jamie. Welcome the offline conversation in terms of the more specifics. But yeah, I think the thing is just to keep it on the agenda and actually be aware of that communication process rather than seeing something escalated to the corporate risk register that only comes to our attention when it gets escalated, and it's making sure those communication flows and we see some of that assurance coming forward. So thank you.
Thanks, Mark.
Thank you for that. Carol, did you want to come in again?
Just very briefly to say that we're obviously with health and safety, we did have a follow-up internal audit report, reasonable assurance, but we are currently in the process of developing with our internal audit colleagues the plan for next year. So we'll take these conversations, the risk register, clearly into account when we're bringing that forward. So hopefully, Mark, and to show our workings out, I think that's been a useful conversation that we'll look to try to bring forward a bit more.
Thank you very much. So, I mean, what we're really considering here is whether the corporate risk register is a true reflection of the current high-level risks, and that the appetite threshold and tolerance for each is appropriate. And I don't think I can't see any questions in that respect. So, can we just receive this for information and agree that it's been appropriately reviewed by the exec committee? Okay, thank you. And I can see that Dave Thomas has joined us from Audit Wales. Welcome, Dave. We have actually had the matter of this audit report heard at the Audit Risk and Assurance Committee. So please go ahead if you would like to.
Certainly. Thank you, Chair. Thanks for the invite today. I know this is a short item, so I won't say too much about this. What you've got in your papers is the annual audit report from the Auditor General, which summarises the totality of the work that we've done at the Health Board in the last calendar year. It includes the audit of the accounts, which of course the board will have had a more detailed presentation on earlier on in the cycle. Also includes the AGW's value for money work, both at the national level where that's relevant to the Health Board, and also at the local level through our structured assessment work and through our quality governance work as well. I won't go through the report, Chair, because I'm assuming that colleagues will have read it. Just to highlight a few issues, obviously the report summarises the clean and unqualified opinion on the accounts and recognises the health board situation in terms of its financial balance there. It draws reference to some of the points around the issues we've identified to officers in paragraph 11, so colleagues can refer to that there. On the value for money side of things, colleagues, if they read the report, will see that we've had to adjust our programme, obviously, to reflect the challenges of the COVID pandemic, and there is COVID-specific work in there. We've done it at an All Wales level, which is relevant to the Health Board around test, trace and protect, and around the vaccine rollout. And that's alongside work we've done on the governance arrangements at WISC, as well as the structured assessment work and the other governance work on quality governance we've done at the Health Board. As a global summary, Chair, the conclusions and the opinions in the report are broadly positive. Where we've identified some areas for further development, they're noted in the annual audit report, and the Health Board has responded positively to those as part of each individual piece of work. So we'd ask that the board note the reports, and I'd be happy to take any questions on any aspect.
Thank you, Dave. I'm sure you're doing your tour at the moment of all the health boards, so we're grateful to you for being here today. I know other health boards have their board meetings today. So does anyone have any questions, please? No? Well, thank you very much. And, you know, we're grateful, as I said, for the report and for your presence here. So
thank you, Chair. Short and sweet. Thanks for the opportunity. Best.
Right, thank you. So the next item on the agenda is the report of the Chief Officer of the Community Health Council, and I can see that Katie Blackburn has joined us. You weren't quite sure, Katie, whether you would make it, so glad you're here.
Thank you, Viv. Thank you. Yeah, I mean, I'm hoping my report is fairly self-explanatory, but I guess what I'd quite like to start with is recognising the pressures that everybody is under at the moment across Wales, but also in Powys, and expressing the CHC's thanks to the staff team in particular for everything that they're doing, but also for continuing to maintain that communication channel between the CHC and the Health Board, and responding extremely quickly to the issues and concerns that are raised with us. So my thanks to you all, and that includes Pete and Claire and Alison in that, giving me the time at these very busy times, or giving the CHC the time at this very busy times. I hope the report is fairly self-explanatory. What I wondered, Chair, whether it might be useful is just to very quickly touch base on the very high level areas that we've pulled out of the response to our planning priorities for next year. I've done a quick analysis this week for another meeting, and I thought it might be useful just to share some of those very high level observations. We had 140 responses from our stakeholders across Powys, and just the headline figures from that, if I can just sort of run through, will be of no surprise and link in with the priorities of the Health Board, but around GP access, access to acute care, dental access, ambulance services, the challenges of the geography of Powys and commissioning arrangements, elderly care, waiting times, communication with the communities, and the issue around prevention of becoming poorly and needing the health services that are provided. I think, as I say, last year we did a GP survey where we had 800 responses, and we'll be following that up this year. And similarly, linking on from what Joy was sharing earlier on, members might recall that we did a survey with young people back end of last year, and considering seeking their views on the impact of COVID on their mental health. And so we will be following that up again this year. We had 380 responses to that. So I feel it's really important that we also follow up on that. I think finally, again, linking in with some of the discussions today, we've got Mind and KAIS, the drug and alcohol charity, coming to talk to full council in a couple of weeks, and we're anticipating that the mental health and the drug and alcohol will become a priority for us next year with regard to understanding the needs of people who access those services, and then just finally, to sum up, maternity services obviously a priority, and we'll continue to do work with understanding the services that are available in relation to gender identity and virtual wards. So that's a very, very quick whistle-stop tour. But I think, it aligns with a lot of the discussions that have been had today and a lot of the work that's, already going on. So we look forward to sharing the detail of those priorities with you at a later date. So, Chair, I'm happy to take any questions or comments or observations, but I don't intend to say much more than that at the moment.
Thank you, Katie. And it was again a very clear report, and it's obvious that a lot of work has been undertaken in the course of the last few months even. So thank you. Any questions for Katie? No, I think it's all very clearly set out there, Katie. So thank you very much, and to all your colleagues. Thank you. And we next turn to the assurance reports of the board's committees. I think we can probably take these as read. They're just there for information. But just quickly, if anyone has any questions, I don't know who would like to come in on that. Committee chairs are here. I think all the committee chairs are here. I'm pretty sure they are. No, Ian's not here. Also, Carol is here as Chief Exec. Are there any questions about these reports? I don't think we really need to dwell on them. No? Ronnie Alexander. Question.
Thank you. I just wanted to say that I think the transfer, or perhaps I should say repatriation, of the local public health team back to the Health Board from Public Health Wales is something that I particularly welcome, because I think it will strengthen arrangements. Yeah. And as with any 2P transfer, there will be sensitivities, and that I hope that those are respected. Thank you.
Yes, thank you. Carol?
Yes, thanks very much. I would just say to Ronnie, absolutely. I had the opportunity to meet with the Public Health Wales team who are based locally, just to indicate how important the public population health agenda is to us as a board, and to work with them in the transfer, etc., and to welcome them with open arms. They've always felt part of us anyway, if I'm honest, and that's what I said. So we've got particular focus on that, Ronnie. I did just want to raise, though, Chair, in my Chair's report for the Executive Committee, there was one item to be escalated, and I wish to highlight that the actual percentage uplift to be applied to funding nursing care was in line with the methodology agreed by the board, and we therefore approved an uplift on the 1st of December, subject to endorsement by the board in terms of the CHC rate, the funded nursing care rate, sorry, not the CHC rate. Yes. So that was just for a matter of record to ensure I drew that matter to the board's attention.
All right, thank you, Carol. Did you want to say anything, Trish, as chair of the patient? Sorry, no, it's not anymore. Patient story, is it? It's the give me a
experience, quality, and safety.
Yeah, experience. We have to take the patient out of it. Yeah, right.
Well, I think patients are at the heart of it.
Yes. Yeah.
We have nothing to escalate to board, but it is a very busy committee dealing with subjects that are really important for our population. So I would ask people to be sure to keep abreast of what's going on in that committee. We did discuss in committee the sort of complex concerns and an overview of that and of serious incidents, and we maintain an eye on that throughout, but there isn't anything particular to escalate. It's just that we keep focused on some challenging areas to ensure the quality and safety of our services and those that we commission.
Right, thank you, Trish. I can see there aren't any questions for you. Just in terms of charitable funds, it's a very busy committee. You can see that there are items brought to the attention of the board listed there. And the important one, I think, for the future, apart from the nurse bursaries training programme, which is great, is the annual work plan. And currently the charity is reviewing the funding streams with certain priority areas. And welcome. We would very much welcome new applications. We don't want the money just to sit there. It needs to be used for the benefit of the patients and people of Powys. So there was that, and Carol, was there anything else you wanted to say, or are you quite happy you've covered everything?
No, Chair, the reports on joint committee activity are there. As with the way in which we're working, there are streamlined agendas for WISC and ESC. And if any board member wishes to pick up any item of detail from any of the papers, I'd be very happy to accommodate that.
Thank you. Okay. I'm conscious of time now because I can see we've overrun a bit. Then Julie, was there anything you wanted to say? Local partnerships, local partnership forum?
No, Chair. Our most recent meeting happened just a few weeks ago and we were able to meet in December.
Good. All right, thank you very much. So is there any other urgent business, please? We haven't had notice of any. In that case, we can close the meeting now. Only 5 minutes late, so we're not too bad, but we have got other meetings that will follow soon, some of us. So the date of the next meeting will be the 30th of March. And thank you, everyone. Diolch yn fawr.
Diolch yn fawr, thank you.